Hello everyone, this is Dr. Pels and I am recording this audio lecture on the concept of elimination, bowel and bladder, and this is part 1, bladder. And please refer to your theory guide for the pages to read and also the objectives to study. First, we want to do a complete history and physical assessment for the urinary system. Some subjective data that you would want to collect from your client is regarding their voiding pattern. So you would ask the client, what is their normal voiding pattern? Do they void every 2 hours, every 4 hours, or do they void more frequently than that? Do they empty their bladder all the way, or do they feel as though they need to go more? Are there any recent changes in their voiding patterns, such as do they have frequency of urination more frequent than their normal pattern, burning or pain with voiding? Does a patient get up more than once at night to void, or does the patient get up at all at night to void? And a male patient, do they have a double stream when they void? Are they able to start their stream when they're trying to void? Some of these symptoms in the male patient could mean that there's a prostate problem, which is blocking the urine from being eliminated. Are there any symptoms such as burning, frequency, or blood in their urine? So you want to get as much information from the patient as possible, and that's your subjective data. For objective data, what is the color, odor, consistency, and amount that we observe when the client is in the bathroom, and if we ask them to save the urine so that we can assess it. Other things that we need to be aware of is the patient grimacing to show us that they have pain. Is there any change in their vital signs if they complain of pain? We need to be aware of what kind of labs to document to be aware of in case the patient may have kidney or urinary tract problems. For instance, you want to look at the BUN and creatinine. If the BUN and creatinine are increased, it could mean kidney damage. What is their output? Their output should be no less than 30 milliliters per hour. Are they having any weight gain? Do they have blood in their urine? Do we see any hematuria on a urinary sample? Is there any albuminuria? What is their glomerular filtration rate? The GFR should be equal to 140 minus the client's age, and that would be normal for their age. So say you have a 60-year-old client, 60 from 140 would be 80. That would be normal for that client. Other things that we want to be aware of is their home situation. How many bathrooms do they have at home? How many family members are fighting for that bathroom? What is their lifestyle regarding toileting? What is their primary concern related to any urinary problems? On physical exam, you do want to note their intake and output. You want to note their body surface, their abdominal girth. You want to palpate over the urinary bladder to see if you feel any bloating, which could mean retention. Any distension of the abdomen could mean retention. You want to note their blood pressure. You want to, if the blood pressure is high, it could be because of urinary retention as well. Do they have any urostomy bag? Do they need to have a urinary catheter? Do they have a condom catheter? Do they have a suprapubic catheter? So you want to take note of how they are eliminating their urine. So physical assessment could be that you can percuss their kidneys. You can tap on their back over the kidney area. If it elicits pain, then you know that there could be a kidney infection or a stone that's causing pain in that region. You want to look at the urethral meatus and see if there's swelling, discharge, inflammation, any discoloration. You want to note if the client has poor tissue turgor because it could be dehydrated. Is there any edema or any signs of any other signs of dehydration noted? You want to examine the urine again for color and odor, etc. Are they giving a fair amount of urine out? You should measure it if there is some kind of concern. The physiology of urinary elimination. First we start with the kidneys. Kidneys have the nephron unit, which is a functional unit of the kidney. Urine is formed here. The glomerulus is the tuft of capillaries surrounded by the Bowman's capsule. Fluid and solutes move across the endothelium of the capillaries, which are in the capsule. The Bowman's capsule filter, the filtrate moves from there into the tubule of the nephron. The proximal tubule, convoluted tubule is where most of the water and electrolytes are reabsorbed. The loop of Henle is where the solutes such as glucose are reabsorbed and other substances are excreted. The distal convoluted tubule is where additional water and sodium are reabsorbed under normal control of hormones. So urine is formed and it is moved from the calyces of the renal pelvis through the ureters into the bladder, which is just a storage unit for the urine, and then it is passed through the urethra. When your urinary bladder gets stimulation from the stretch receptors in the bladder wall, the stretch receptors transmit impulses to the spinal cord to elicit a voiding reflex. The internal sphincter relaxes, and then, if appropriate, the urine is released through the urethra with the external sphincter. Some of the factors that affect voiding. We need to measure the intake and output at any time that we feel there is a deficiency in voiding, or person has surgery, or certain medications are used, and we want to make sure that they are putting out as much as they are taking in, or certain disease processes. Medications such as diuretics can cause the client to urinate more, and are given to lower blood pressure by eliminating some of the urine in the vascular system, some of the fluids in the vascular system, excuse me. Pyridium is a medication that is generally used to decrease the pain of urinary tract infections. It will not cure a urinary tract infection. Pyridium does turn the urine very orange in color, and it can stain clothing. So we always want to make sure that the client is well aware of that possibility of staining their clothing so that they don't ruin their clothing. Something that we want to make the client aware of is that it's important to exercise your muscles in the lower pelvic area. The pelvic floor, it is especially important because that is what holds our kidneys, our bladder, uterus, prostate, etc. in place. So we often recommend Kegel exercises, and Kegel exercises are an exercise where they tighten the anal sphincter and the urethral sphincters, and hold for approximately the count of 10, and they can do that as frequently as they want, because no one really knows you're ever doing these exercises. But it is a great exercise to strengthen the pelvic floor and hopefully keep the organs of elimination from falling or drooping, and that will cause better voiding and less incontinence. It should cause a reduction in in the inability to control urine. If the patient is having problems voiding, eliminating their urine, they can have a retention of urine in the bladder, And as many of you have found out by being in the clinical setting already, that you can use a bladder scan to check to see how much urine is being retained in the bladder. Generally speaking, in most places, the doctors will say that they like to see no more than 100 milliliters in the bladder, so that they often will give you an order to do a straight cath to get the urine out of the bladder, especially if it's a large amount, because it does cause pressure and stretching of the bladder. Some pathological conditions, such as kidney stones, can affect voiding. They can block the urine from coming through the ureters, which can be very dangerous to the kidney, because urine backs up and causes retention in the kidney calyces. Chronic kidney disease is a problem with your kidney, where your BUN and creatinine rise, and it could cause danger to the kidney. The kidney could lose its ability to process blood through the calyces and be able to eliminate waste from the body, which could cause the client to have dialysis. Urinary failure is where the kidneys have failed, and the patients are usually on dialysis of some sort, whether it's peritoneal or direct kidney dialysis. Hypertension can cause kidney problems, kidney failure, if it's not treated, if it's let go for long periods of time. There is a chance of kidney failure, and including heart attacks, strokes, etc. Surgical and diagnostic procedures that you may see done to your clients that could affect their ability to void would be a spinal anesthesia. Spinal anesthesia can cause a relaxation of the muscles and urethra, colon, etc. Things that will also cause problems with voiding could be that if they have an infection or kidney stone, the urine could end up being pink or red in color because of blood. Cystoscopy is a procedure to check out the bladder. It's a tube that has a scope put into it so that the physician can see inside the bladder. They can detect masses, cancers, tumors. They can detect whether the patient has a lot of erosion of the bladder wall. They could have chronic cystitis. There could be displaced urethral meatus. Ureteral meatus on the kidney to cause, a continual bedwetting problem in younger people. So cystoscopy is used to diagnose any problems that are going on in the bladder or any association with it. Ureteroscopy would be further up into the ureters, and that's done with a much smaller tube. Some altered urinary elimination keywords are polyuria, which is a production of large amounts of urine unrelated to the intake of fluid. Oliguria, which is less than 30 milliliters per hour on average over the course of the day. Anuria is putting out less than 100 milliliters of urine in a 24-hour period. Urinary retention is when the client cannot initiate voiding or empty the bladder. So frequency is an increase in times of urination. Usually it's done with smaller amounts. The bladder doesn't empty all the way, so the patient has to go more frequently. Urgency is that sudden, strong desire to urinate, which could be leading to incontinence for the client. Dysuria means painful or difficulty with voiding. Hematuria is blood in the urine. Enuresis is the uncontrolled discharge of urine. Nocturnal enuresis is voiding at night uncontrollably during sleep. And neurogenic bladder, which is not on here, but that can be where the nerves are impaired, so the patient does not perceive the bladder fullness and doesn't get that sensation to control the urinary sphincters. So types of urinary incontinence. There are 4 primary types of urinary incontinence. Stress urinary incontinence is the loss of urine less than 50 milliliters that occurs when there is a sudden increase in the intra-abdominal pressure, such as the client or patient sneezing, laughing, lifting something very heavy, coughing. Any kind of sudden increase in the intra-abdominal pressure will cause loss of urine. Urge incontinence is the state in which the individual experiences involuntary passage of urine, occurring soon after a strong sense of urgency to void. And this can happen especially when they're drinking caffeine, alcohol, increased fluids, increased urine concentration, over distension of the bladder, like people holding it too long and not being able to get to a bathroom, and in the case of decreased bladder capacity, sometimes there can be only a few drops of urine that's released, which is not too bad for most of the patients that I've seen, but sometimes it can be as serious as soaking through all of their undergarments, which is very hard for them to tolerate. Overflow incontinence can come from the bladder being too filled, and when it's at that point, they just can't hold it any longer. There can be a mixed urinary incontinence, which can be partially urge or stress incontinence or overflow incontinence. There is also one not listed on this slide, and that is functional incontinence, and that's the involuntary, unpredictable loss of urine that it occurs when there is like an inability to get, say, to the bathroom in time. If a client's living at home, maybe their bathroom's upstairs or something, and they can't really climb stairs quickly, or if it's in a hospital situation where the client needs to go to the bathroom and they can't get someone to help them up, so they start to try to go to the bathroom on their own, but they can't get there in time, so they have a functional inability to get to the bathroom. That's usually as a result of limited mobility due to arthritis, surgery, etc. And a neurogenic bladder is where the lack of nerve control of the bladder just causes total incontinence in most cases. Lifespan considerations. Please remember that in among most individuals, that approximately 5 times a day is how often they will go to the bathroom while awake. Usually, in the younger individual, people will sleep through the night and not have to get up at night to empty their bladder. Often, as clients age, then they may have to get up at least once or maybe more frequently during the night to void. The younger clients, younger than 3 years of age, have a difficult time concentrating their urine, so they have a problem with not being able to control urination. Elderly clients, it's the same thing after the age of when they're in their 80s or more, then they also lose that ability to concentrate urine. So they have a harder time to control urination. Pregnant women, because of the weight of the baby that's pressing on their bladder, they could have problems with controlling their urination. And women who are menopausal, due to the fact that they can get some drying in and around their vaginal and urinary areas, they sometimes have trouble with controlling the urinary sphincters. And women who are aging should practice Kegel exercises to strengthen that pelvic floor so that they can control the sphincters and the muscles more appropriately. In some circumstances where women have had hysterectomies, the muscles have been damaged, so it is very difficult for them to regain some of that strength of the pelvic floor muscles. So it is recommended that women start doing Kegel exercises probably in their 40s or 50s to keep building that pelvic floor so that they don't get such a weakness as they age. Men with hyperplasia of the prostate, when it's enlarged, as it shows you in this slide, it can block off the urethra so that the bladder is not allowed to empty efficiently, which makes men have to go to the bathroom more frequently to try to empty their bladder frequently. So they end up getting up at night more often, and sometimes when they try to start their stream, all they can get is a little bit of dribbling instead of a full stream. Some control issues that continue to happen during the older ages. According to your book, older adults over the age of 65 have some decreased ability to concentrate urine. I would say that's not every individual that's over that age, but it could be some that start to get that difficulty in concentration of urine. So they have a decreased bladder capacity in some older individuals, and elderly women are at a higher risk for bladder infection because of this difficulty to empty their bladder at times. And when urine is held into the bladder, it's at a higher risk for infection. Men who have BPH and have an inability to empty their bladder also have a higher risk for infection. Remember that some foods or fluid intake can affect how people are voiding at any age, and alcohol and caffeine inhibit the release of ADH, which is antidiuretic hormone, which then increases urinary output. So that's something that you can teach your clients, that they may need to decrease their alcohol or caffeine intake if they are, having problems controlling their urinary output. Medications, any diuretics are, of course, primary medications that will cause you to, lose a lot of urine. So if people have some kinds of incontinence, they have to know that these things can affect their incontinence as well. So some things that can be affected by problems with controlling your bladder. Of course, it can change your activities of daily living. If you are at the age where you're still working and you're trying to maintain a job, it's very difficult if you're continually having to run to the bathroom. So women in their 40s and 50s are still in a working age, and if they've had problems with stress urinary incontinence or urge incontinence or even full incontinence related to surgeries like hysterectomies or having a large number of children or having large babies, it can cause these control issues. So it changes their abilities to function during the day. It can be a big problem with social relationships too, because um, they don't feel like going out and socializing if they may have wet clothing, or may have an accident where they're going to all of a sudden spill urine when they're trying to do something like maybe go play tennis or do a sport or something. So oftentimes it can make a big impact on their social relationships. Women tend to be more housebound when they feel they can't control urine. Um, so it does make a big change in their habits. And of course, if we have urinary incontinence, it can cause skin breakdown, even if the client is not in the hospital or bedridden. Anyone who has urinary incontinence, and if they're wearing undergarments, clothes, pads under their clothing or whatever, all that wetness against their skin can cause tissue breakdown. And it's much, much worse if they're bedridden or in a hospital and they can't take care of themselves. They are dependent upon nursing staff to be able to change their diapers so that their skin is protected. So some discomfort that may come from urinary problems, um, like we talked about in the history taking, is inflammation and infection. Inflammation can be from, um, you know, um, fungal infections or bacterial infections. If we have a yeast infection, that's a type of fungus, and that can cause inflammation, can cause much itching and a thick white discharge, which can cause a bladder infection if that's not treated, because it's all very close in that area on female patients. Um, what if the patient has burning with urination? What does it mean? It can mean a fungal infection. It can mean a bacterial infection, bacterial vaginosis. It can mean a sexually transmitted infection, which is a stage worse than your normal bacteria or fungal infections. So they need to be tested so that they can be treated and hopefully get rid of the burning sensation if the cause is treated. Um, Bladder distension can be seen with urinary retention. When you're examining your patient, you want to see if the lower abdomen over the bladder area is distended. You can do that through your assessing skills. Observation and inspection is something you do first, and then you can gently palpate that area to see if it feels enlarged right over the bladder area. When you get into OB, you will see that sometimes you can feel a bladder shift in women when they're pregnant, because as the fetus grows, it causes the bladder to shift to one side or another. So these are just some things that you can be aware of with your assessing skills. Bladder training is something that we try with our clients who have bladder problems. We want to try to get them to postpone voiding so that they can have more time in between voidings. Sometimes after a client has surgery, we want to try to get them off of a Foley catheter if they've had an indwelling catheter. So we may be clamping the catheter on intervals to get the bladder to see how it feels to be full with urine again, so that the client does not feel that they need to empty their bladder immediately when there's a small amount of urine in it. And sometimes we can teach the client to resist that urgency feeling that they get by distraction. Say, watching a TV show or playing a game or something like that. What we try to do is get them to go like an hour without urinating. If they've been going more frequently than that, we then strive for 2 hours, because when clients have activities that they like to attend, getting out of the house, going to a movie, doing other activities, maybe they have to go to a laundromat or go grocery shopping, it does make an impact on their life if they can't stay out of the bathroom long enough to do that. So we try to get them to increase the time between voidings and resist that urgency to void. The goal is to lengthen the interval in between voidings. You know, we have to do a lot of patient education and talk to them, and sometimes just, you know, see how they feel about all that. Is it something they think they can do, and get them to try it, and then as they try, make sure that they're not having too much pain when they're trying to achieve this. Um, we want that the patient is not going to rely on the ability to urge, to inhibit the urge to void. You know, we want them to be able to, you know that they should try to go, you know, avoid that urge as much as possible, but we don't want them to think that they can't void if they get that sensation. We just want them to try to hold it off a little bit longer each time until they can have, you know, a good 2 hours, and then maybe strive for 3 hours, you know, to train their bladder. We want them to practice slow, deep breathing when they feel the urge to void, because sometimes that will diminish the urge and sometimes even make it disappear for a short period of time. These are just some examples of urinary catheters. The indwelling catheter is one that goes directly into the urethra, and it is attached to a bag. There are a couple of different types of bags. One has a meter on it that can measure the urine more accurately. The other is a bag which you cannot measure accurately from just the bag. You need to empty the urine into a graduated pitcher so that you can get a more accurate reading on that. Whenever you use an indwelling catheter, make sure that you do not put the catheter tubing underneath the client's leg, because it can cause irritation on their skin and cause a breakdown. You want to make sure it's above their thigh and attached with this device that you see on the left of this PowerPoint slide. And when you do remove these, they stick really well. So you want to make sure that you use some kind of alcohol or water and soap just to kind of release the stickiness so that you don't tear their skin, because this is a very sticky product, and you want to be careful. What you're seeing in the middle slide is a type of catheter, external kind of catheter. I've seen these used for female clients. I've seen them used for our pediatric clients. They can be stuck to the area around the urethra, like the mons pubis. It is kind of difficult when you have hair there, so removing it can cause removal of the hair as well, which would be very painful and uncomfortable for the client. On the other picture on your right, it is showing you a condom catheter, which I'm sure some of you have seen by now since you've been in the rehab area. And this just fits over the penis as a condom would, and it's attached to a bag. It can be attached to a leg bag, which is what this client has, which does make it easier for the client to be able to get out of the house, go to, say, get groceries or go to a movie or whatever. They don't have to go to the bathroom as frequently. They can just go into the bathroom and then empty the catheter bag when they go to the bathroom. They should always be aware that they should check that bag and make sure it doesn't get over full, because then they could have spillage and leakage. This slide is all about specimen collections. We have different kinds of specimens that we collect with our clients or teach them how to do. Some doctors will order a first morning urine, in which case it should be the first void that that client does as soon as they rise from their bed. Other doctors may order, a collection of the second void, which would be empty the bladder first, and then the next time they void, they would collect that specimen. The clean catch urine is where you teach the client to use a little cleaning pad that comes in the pack to clean off the meatus on a male. They just clean around the meatus of the penis in circular motions as they move down the meatus, and then void into the container. It just cleans up any residue that might be around the opening of the penis. On a female, we teach them to clean one side toward the rectum and with one little wipe, and then the next side toward the rectum with another wipe, and then right down the center with the last wipe, and throw away, discard those wipes, and then they should void into the container. Midstream catch is where the client starts to void and then stops, and then they put the container under the urethra and void again, which is midway, and then they give approximately half of that little container full, and then they stop again, and then they can void the rest of it in the toilet. So it's like you start, stop for a second, collect the specimen, stop for a second, and then void the rest of it in the toilet. A straight cath is where we have to get a catheterized specimen or relieve the bladder if it's over distended with a catheter that is not indwelling. In other words, it cannot blow up a little balloon to keep it in the bladder. It does not have a balloon on it. It just goes straight in, and then once you empty the bladder, you take the catheter out. Oftentimes you'll see this with people that are like maybe paraplegic. They learn how to straight cath themselves so that they can go into the men's room and or the ladies' room and empty their bladder on their own with a straight catheter, and they don't have to have a Foley catheter indwelling all the time, so they don't have a problem with holding their urine. They have a problem with releasing their urine. Often the nerve impulses are not there to tell the sphincters to open so that they can release the urine. A post-void residual is where you ask the patient to urinate and empty the bladder as much as they feel they can, and then you may have to go into the bladder with a straight catheter to check and see what is left. I would say more recently, now that we have really great bladder scanners, the doctor usually orders bladder scanning after they void. So rather than going in with a straight cath, they just check it with a bladder scanner to see how much is retained in the bladder. Generally speaking, most physicians or providers don't like to see the client have much more than 100 milliliters of urine. I have not heard of any place that they've seen it more than that, but it could be. It could be 150. I mean, it depends on the physician. A timed urine specimen is, for instance, say a 24-hour urine specimen. It could be slightly different. I guess it could be 2 days. Most of the time, though, I do see 24 hours rather than longer than that. So the patient is often told to start with the first urine in the morning, and then they would end at the same time the next morning, so it would be exactly 24 hours. Most times this urine specimen is kept on ice, so you can, like the container that you see, the big red container there, could be kept in a bucket on top of some ice, and it would just keeps the urine fresher, until you turn it into the lab and they examine it until pathology examines it. A contamination would be if you were trying to get a clean catch urine and the client didn't clean well around the areas, or if you were helping a patient do it in the hospital, maybe you didn't clean as well, so the urine specimen got contaminated. So it's all about not using the proper technique to collect the urine that's needed for pathology. These are just examples of diagnostic tests that can be used. We talked about the bladder scanner. That is something you've probably seen in most of your rehab areas currently. The types of tests that you can use to check the urine would be a culture and sensitivity. That's done with usually a regular urine analysis. Because with a culture and sensitivity, they can tell if there's a bacterial growth and what kind of antibiotic is successful in treating that bacteria that's picked up. Creatinine clearance is one type of 24-hour urine. I've also seen it for protein in the urine, so there can be other types of 24-hour urine collections. But as I was talking about in a prior slide, that's collected over a period of 24 hours and then taken into the lab as soon as you can after it ends. The renal function tests that we do are BUN and creatinine. Blood urea nitrogen and creatinine are two that indicate if there's kidney damage. Glomerular filtration rate, which we went over before, is 140 minus the client's age, which would be the normal value. If it is, not the normal not at the normal value, then there could be an issue with the client's kidneys. So it would mean that we have to further examine their kidneys. And there are, of course, kidney tests that can be done. An IVP is, a test where they use dye to check the kidneys. It's shot into a vein and then it goes through the system and they do scanning so that it can see, if the kidneys are functioning appropriately. We can also do nuclear studies of the kidneys, ultrasound. There's a number of different types of kidney exams that can be done to see if the kidneys are functioning appropriately. The urine analysis, just to give you a little example, there are patches on the side of the bottle that if you get a urine sample and you dip a dipstick into the urine sample, the colors that it changes on the dipstick can show you what the pH is of the urine, what the specific gravity is, whether there are nitrates or not, if there's blood in the urine, if there's glucose in the urine, if there's protein or ketones in the urine. Each one of those little sections up there can indicate that. We don't usually do that anymore. We were doing that more consistently in probably over 5 years ago. More recently, they prefer that these are done by pathology, just to prevent mistakes from occurring, because there are people that have difficulties with picking up color, and they feel that, without knowing for sure if you can detect color well, that there might be a false reading. That's one of the reasons why they have changed it all to be done in pathology. We don't want nitrates to be in the blood. Sometimes nitrates can mean an infection. If there's blood in the urine, it can mean an infection. If there's glucose in the urine, it is something that means that it's from a diabetic who's not controlled well. We should not expect our diabetics to spill glucose into the urine. It's only if their glucose is really high and they're not really controlling it well. Protein or ketones in the urine. Protein can be indicative of a urinary tract infection as well. Ketones are generally seen when people are dieting, and certain diets that cause muscle or tissue breakdown. I think it was the Atkins diet that typically showed ketones in the urine. It's something we don't want to see in the urine unless people are trying to diet, but you have to be very careful with that. You don't want them to go overboard on releasing too much ketone. Some examples of nursing diagnoses can be impaired urinary elimination. With impaired urinary elimination, you would want to give a related to. You would then give some as evidenced by and related to the specific problems that's happening with your client. Readiness for enhanced urinary elimination would be a diagnosis, that is total right there. It says all that it needs to say. You don't need to give any related to or as evidenced by or any risk factors. So if you're going to use a diagnosis that's related to a type of urinary incontinence, you need to be able to identify that type of urinary incontinence, such as, urinary incontinence, urinary urge incontinence, urinary stress incontinence, urinary retention. Any of those types of things need to be identified more specifically. Related diagnoses are, some can be used as risk for infection, low self-esteem. Low self-esteem is something you can use with somebody who has incontinence problems, because they really tend to not want to go out and enjoy themselves socially, because they're always worried about urine leakage and urinary incontinence. Disturbed body image, fluid volume excess or deficient fluid volume, deficient knowledge, risk for caregiver role strain. If you are someone who's trying to help a family member dealing with this situation, it can be a role strain for the caregiver, and sometimes the caregiver needs a break so that they don't become angry or upset with the person, because that person who has that issue, can't help what they're doing. So risk for social isolation in those clients that don't want to get out and participate socially. Some goals that we try to achieve might be to achieve at least 1,500 milliliters of output a day, which would be a short-term goal. We might try to achieve replacing fluid losses. We may want to, regain some type of a normal urinary output for that client, whatever their normal might have been to begin with. Some contraindications in some clients, of course, might be renal failure or heart failure. Of course, you have to, maintain a fluid restriction if they're on an order for fluid restriction, in which can be typical in your heart failure clients. Maintain normal voiding habits with the use of diuretics or medications. And dealing with cognitive issues or mobility issues to maintain normal voiding habits. There might be just getting the patient to the bathroom in time, or offering a commode that could be at the bedside so that they can get on the commode efficiently. Answering the call bells in time so that the client does not feel that they have to rush to the bathroom and maybe fall and fracture something because they're trying to get to the bathroom. It does happen a lot in the older clients. We want to assist them with toileting, which would be some interventions that you could use. Teaching them to wipe front to back. Teaching them about the temporary devices that they can use, like bedside commodes or urinals. And you want to check the patient frequently, make sure their call bell is in place, make sure they have good lighting, and make sure that their handrails are up at least 2, not more than that. You can do 3, but never 4, because that is a restraint. We want to prevent UTIs at all costs, because urinary tract infections aren't easy to heal. If they happen in the hospital, it's hospital acquired, and that's extremely bad for the hospital to have any kind of hospital acquired infections. So we try to keep that down to a minimum. We want to make sure that they get enough fluid intake, that we maintain their normal voiding habits, as I said earlier, get their pelvic muscles in better shape, maintain their skin integrity as well. We want to promote saving their skin integrity. And we want to use external devices as necessary. We want to provide some care for those patients that do have to have urinary catheters, suprapubic catheters, etc. We want to make sure that we care for them in an efficient way to prevent infection. That ends this portion of the elimination chapter on urination. Remember to look into your theory guide to see which pages you need to cover to go over this chapter. Thank you.